Well, thank you guys so much for having me here today. So I think my presentation is kind of about this idea that we've only seen the tip of the iceberg, which is hopefully not to scare anybody, but kind of just as a reality check of some of what I've seen in terms of COVID-19. So I used to read Time Magazine kind of religiously, and my favorite part of Time Magazine was always the by the numbers section. So just as a refresher for those of us who haven't been keeping up with them as much, about 185,000 patients in the US have been hospitalized from COVID-19 thus far. And the estimates are that about 25% of patients who are hospitalized will require care in the ICU. And those are the patients that I care for, oftentimes in our medical ICU, as was alluded to. And so that amounts to about 46,000 patients thus far who've required care in the ICU. And I think that that's a lot of what we see on the news. That's a lot of what we hear about. It's these biocontainment units that have been built, and it's transporting patients in their quarantine, and it's the masking and the gloving and the way to protect and keep the provider safe. And that is obviously critically important. Like I said, that's a lot of the bread and butter of what I've been doing the last 18 months. So I understand kind of the emphasis and the need to focus on this. But I think that this kind of overlooks something else, which is that there's actually more than 33 million cases of COVID-19 in the US, and this was data as of yesterday. So if you kind of take a step back and don't just look at that critically ill population, but look at the whole population, 33 million cases is kind of a staggering number. And then if you look at, again, what the data is coming out and showing is that about 50% of these patients are going to have symptoms of COVID-19 that persist for more than 30 days. And you may think, oh, well, those are just the critically ill patients who are in our ICU and they're on mechanical ventilation. That's simply not true. So a lot of these patients were non-hospitalized patients, and they still have symptoms at 30 days. So about 42% are non-hospitalized patients. And then 30% of patients who have what they report as mild symptoms initially are having ongoing symptoms at 30 days. So this 50% of patients who have persistent symptoms doesn't just apply to those ICU patients who I care for. This applies to the larger population of people who've had COVID-19. And so the point of all these numbers is really that we're looking at 17 million plus patients who are going to have prolonged symptoms of COVID-19, and that's in the US alone. And so I think the critical care problem, the lack of access to medications, the uncertainties on how to treat these patients who are dying in the ICU on mechanical ventilators, that is a huge problem. But in many ways, it's really just the tip of the iceberg for what is to come. So just so we're all using the same language, this prolonged symptoms related to COVID has been called many things like post-COVID syndrome or long hauler syndrome, but the terminology that's most appropriate is the post-acute sequelae of COVID-19 or PASC. And then just again, so we're all defining it the same way, is according to the CDC, this is defined as symptoms of COVID-19 for more than 4 weeks. And that's kind of thought to be a subacute form. And if you have symptoms of COVID-19 for more than 12 weeks, that's more consistent with a chronic form. And this is not meant for you to be able to see all the numbers or read every single bubble on here, but just to understand that some publications are actually estimating that we may see 80% of patients having prolonged symptoms of COVID-19, but whatever the actual number is, whether it's 50% or 80%, this is a disease process that's going to affect multi-organ systems, right? And so we have neurological symptoms, including brain fog and confusion, memory loss, psychological symptoms like anxiety and depression, persistent pulmonary symptoms like shortness of breath, and cardiac symptoms like chest pain and heart palpitations. People complain of joint aches and muscle aches, lots of exercise intolerance. So it really can affect patients from head to toe and can involve any organ system. And again, this is not meant to really go through all of the finer details of this, but this is some research that came out of Nature recently. And really, it's just looking at what is the burden of disease and comparing specifically the burden of disease to patients who were critically ill with influenza. I think we all know by now that COVID-19 is not influenza, but just as a reminder over here on the right side, if you look at the relative increase in burden of disease compared to influenza at every organ system, and I had to cut off the table just so it would fit, but at every single organ system, the relative burden of disease is exponentially higher with COVID-19 compared to influenza. So don't be deceived. This is not influenza. This is not even H1N1. This is an entirely different beast. Similarly, in the same paper, they talk about if you look at the excess burden of disease in patients with COVID versus influenza. If you look at hospitalizations, the excess burden of disease is 28-fold higher. If you look at death in these patients, it's 28-fold higher. And if you look at outpatient encounters, it's 6-fold higher. So there's a tremendous burden of disease that's happening in people who've had COVID-19 and people who survived COVID-19, and it's lasting for a very persistent amount of time. So I just wanted to kind of quickly go through what I think some of the problems are based on kind of what you guys know now is this massive burden of post-acute sequelae of COVID-19. So the truth is there's simply not enough clinicians to see 17 million new patients. We certainly haven't trained 17 million new providers or any fraction even close to that. And so there's not enough providers to see these patients. And even if there were enough providers, there simply is not enough clinic space or appointment times or actual physical offices to go and see these patients that accommodate them. There's not nearly enough clinicians who have an interest in or an expertise in the post-acute sequelae of COVID-19. And this is not something that we're including in our medical curriculum readily. So we're not really increasing the number of physicians who have any expertise in this. I think just to reflect kind of what is a logistics problem, who should even see these patients, right? I told you they have multi-organ system involvement. So should they see neurologists or pulmonologists or cardiologists or all of the above? How do we identify who needs to be seen in a follow-up clinic? Who's likely to most benefit from being seen? Who is going to get no benefit? Who has permanent injury that's not going to recover? Who would get the most benefit from targeted intervention? And how should we triage these patients? Like I said, you can't fit 17 million in at a time. And of course, that number just continues to go up because every day we still have more cases of COVID-19 being diagnosed. I included here and tried to cross out all the names, of course, but this is my clinic schedule from yesterday. So I had a 3-hour clinic where I had 8 patients. All patients were post-COVID-19 patients, just as kind of a general gestalt of their symptoms. My first patient had been having shortness of breath for well over a year. The second patient was so fatigued for a year now that she was now unemployed. My third patient was on ECMO for 90 days. In the intensive care unit and was recovering from ECMO, was actually doing very well. This patient was a firefighter who had dyspnea that caused her to take a leave of absence for 3 months from her job, which was now recovering. This patient's primary complaint was knee pain, so probably not in the right clinic since I'm a pulmonary doctor, but was referred because they are post-COVID-19. This patient had so much brain fog that they had lost a $100 bill with no recollection of where they put it, ultimately was found by their significant other in the refrigerator. And this patient had fatigue and chest pain that persisted for well over a year. So this is kind of the wide array of the different patients that are coming to a post-acute COVID-19 clinic or PASC clinic with their different complaints. And I think it just reflects, again, sort of the confusion in who should we see and who should be seeing them. I think in one model you can see here, this would be kind of one type of multidisciplinary clinic that I think would be appropriate for a patient who is recovering from COVID-19. And this model, it might be hard to see, the patient of course is at the center of it, but I've included here a dozen or so different specialties that I think would be appropriate to take part in a multidisciplinary clinic, ranging from pulmonary to rheumatology to neurology to sleep medicine, pain management, PM&R. This really does encapsulate pretty much every discipline of medicine. I have patients who have vocal cord dysfunction and need to see ENTs. I have patients who have ongoing clotting problems and need to see a hematologist. So here, basically, you have a multidisciplinary physician clinic where pretty much every discipline of medicine is reflected here. And then I think in a different kind of multidisciplinary clinic, you have the physician who's seeing the patient, someone like myself, but then you have the other services which are also critically important, like physical therapy and occupational therapy, vocational rehabilitation counselors. Like I said, if you're a firefighter and you get COVID-19 and you're so short of breath that you can't return to work, it's really not probably fair that you're simply out of work permanently for the rest of your life, but having vocational rehabilitation counselors available would be critically important. So this is a different model of a multidisciplinary clinic where each of these representations here are critically important to the patient's recovery. But if you then blend the models together to really accommodate what the patient actually needs, this is what this model would look like, which is overwhelming, I think, because now you're looking at 20 or so different types of providers that are necessary to care for a patient just to recover them back to their baseline. So I think back to the logistical problems, how do you get a patient to see all of these providers? So now, in addition to one provider needing to find time and space for 17 million people, now 15 or 20 different providers each have to find space for these 17 million people. It's just not possible. It's not logistically feasible without training infinitely more providers. and perhaps maybe even more patient-centric is how do you get all of these providers together in one space to see the patient together, instead of having a patient see 20 different providers, having 20 different providers be in one space and the patient comes there. That's also quite logistically challenging. I think we also have huge knowledge problems here. So as I said before, we really don't know who's going to get PASC or for how long. There's different reports in the literature that perhaps patients who are sicker from their initial COVID diagnosis may be more susceptible to prolonged symptoms related to COVID, although that's not always the case. Perhaps patients who are a little bit older are more susceptible to PASC. There are some proposed gender, race discrepancies between those who do and do not get PASC, but it's not entirely clear. And relatively speaking, we're very early on in the process of understanding COVID-19 and the process of recovering from COVID-19. As of right now, we don't have any treatments for these patients. So I can have a 17 provider clinic where a patient comes to be seen and I can do a full assessment, but I really don't have anything to offer them for their treatment at this point. And I think as we've learned with most things during COVID-19, good clinical practice and having the answers to what the best treatments are for these patients is really going to come through enrolling your patients in large randomized clinical trials, but there really isn't equitable access to this. So some cities and some hospitals, some programs are running dozens of clinical trials and others have no clinical trials running at all. And this is a patient population who's already somewhat disabled, short of breath, having mobility problems, they've been unemployed. It's not really reasonable for me to tell a patient to travel from Baltimore to a different city, for example, to enroll in a clinical trial. It really just compounds the issues that they already have that are underlying their current illness. I think without a doubt, hopefully I've been convincing that this is the next public health crisis. So I think coming on the heels of the acute issues with COVID-19 and our patients who are still sick and dying in the intensive care unit is going to be this massive population of people who require prolonged and very intensive and multidisciplinary care. And so I think, what are the pathways forward? So I think we have to have a systematic approach to follow up these patients. Perhaps something like a phone-based or virtual screening where all patients who are diagnosed with COVID-19 get some sort of phone call to ascertain whether or not they have persistent symptoms. Perhaps the first visit needs to be with the primary care provider. A systematic assessment needs to be done of the patient's needs, and then patients can be referred either to specialty multidisciplinary clinics or post-COVID clinics if necessary. I think that we need support and infrastructure to really build and run these multidisciplinary clinics that include all the disciplines that are needed for patient recovery. And I think we need to ultimately probably start to reward and incentivize trainees to do primary care, which has been a problem in medical education and training clinicians for a long time. But I think now more than ever, we're going to have a huge population of people who really need really diligent, thoughtful primary care providers who can assess what their needs are, provide them with long-term care, and refer them out to specialists when their needs are beyond what they can provide. I think we need a much more comprehensive dive into research. So I think that we need to better phenotype this disease process. So as I see in my own clinic, while all of these patients have a diagnosis of post-acute sequelae of COVID-19, there are different patients who were in our intensive care unit for 2 and 3 and 4 months who have arguably a different phenotype of the post-acute sequelae of COVID-19 than the patient who's been struggling with symptoms from COVID, but was never sick enough that they had to go to the hospital. Perhaps these are different diseases and these are different populations. They may mean that they need different kinds of providers, different kinds of follow-up, and maybe they're even different patients for interventional trials. I think in general, we need people to come to the table with bright ideas and suggestions about how to care for these patients. Certainly they need care from us, but I think if we don't do something to modify our current system or to work out solutions to provide them with support, we're going to end up with a lot of people who don't have the care that they need. So I'm hoping that hopefully this brings some smart people together to start to brainstorm what we can do to better provide support for these patients.